In this lecture, we're going to talk about hearing assessment. Now, you may have had similar information in the past that was basically from an audiology perspective. But in this place that we're going to be in this semester, we're going to be talking about not only what are the practices that an audiologist might use, but what that means to someone who is doing and performing oral rehabilitation. So we're going to add that lens into some of the information that you've probably learned previously. So we're going to talk about hearing assessment. Similar to speech screening and language screening, we have both our assessments that we do for speech language pathologists, or pretty much any assessments. We have a screening component and then a diagnostic component. For both the screening and diagnostics, we have objective and behavioral components. So let's talk about what that might look like. So when we talk about hearing screening, it depends a lot what we do based on the age or the developmental level of the person that we're screening. So for a newborn, they're not able to give us any sort of responses that we are able to ask them to be able to do. So we need to rely on objective measures for screening for newborns. For toddlers and preschoolers, we might be able to integrate in both behavioral and objective measures depending on the developmental level of the child. As we move more into school age children, we can use both behavioral and objective measures. And you may have done some screenings as one of your practicum experiences, or you may have seen or participated in screenings before where children will be able to raise their hand or drop a block when they are hearing. And that gives you sort of a probe at different frequencies. That's just sort of a high level idea of what they're hearing. For adults, we basically just rely on behavioral measures. Results of screenings are interpreted on a pass or refer criteria. We don't really say pass fail. Really, the idea is pass or refer because a pass means that there's no audiological follow-up required at that moment. Refer, it doesn't mean that the person fails. It means that we really need to get more in-depth audiological diagnostics, and so a follow-up is required. We don't diagnose a hearing loss type or degree from screening results. So this leads us to a diagnostic audiological assessment. This gives us a lot more depth on the type of hearing loss, the degree of hearing loss, the configuration of hearing loss, and the laterality of the hearing loss. So type of hearing loss is really relates back to what we talked about last week about the ear and the place of the hearing loss that might be. Is it a conductive hearing loss, a sensorineural hearing loss, a mixed hearing loss? And so that's really related to the type. The degree of hearing loss is going to relate to how it falls sort of vertically on the audiogram from a normal hearing loss all the way down to profound hearing loss. Configuration is going to be what does the threshold pattern look like? And we'll talk about what that means as an interventionist as well. And then the last part that we need to be able to kind of assess or to be able to get some information on is the laterality of the hearing loss. Is it unilateral hearing loss or a bilateral hearing loss? And are those hearing losses from different ears? Are they similar or are they similar or are they or symmetrical or are they asymmetrical? And do they look different from ear to ear? So this needs to be done with both adult and pediatric patients. And we just have to make sure that we're adjusting to the child's age or the client's age when we're looking at the audiological assessment. So the reason we do diagnostics is really to get a best understanding of what that hearing loss looks like, and then also the thresholds of hearing. We need to be able to understand really what that hearing loss looks like across all frequencies, across the different ears, and because we need to be able to manage that hearing loss if we're living in an oral rehabilitation world where we're going to try to do something with the hearing that they have or the technology they have. So if we better understand the thresholds of hearing, then we're better able to fit the hearing technology. So if we don't get a great assessment, we can't do a great management. This is true about all of rehabilitation. We have to have a strong assessment so we can fit the technology or the intervention based on the assessment results. And when we have the technology and it's fit appropriately, this should give us the opportunity to optimize access to language through sound. And this is called audibility. Audibility is the ability to truly use the hearing technology when you have a hearing difference to be able to access language and communication. But it does take this process of having a good audiological test, well-fit hearing technology that's worn full time. Then we can truly access sound. We can access language through sound if we have these things that work together. In working with pediatric populations, this is truly an interprofessional process. This is not just something that the audiologist can do one and done, and then go out into the child goes out into the world and is able to access all of the sounds, all of the information. It's fit perfectly every single time. This is interprofessional. And the more you can understand everyone's role in understanding diagnostics and verifying the fit of the hearing technology, the more powerful that hearing technology will be in accessing language and communication. So there are different types of behavioral tests that we do depending on the age or the developmental level of the child. So behavioral observation audiometry, or BOA, is really from birth until the child can condition to light and toy reinforcement, or VRA. This requires observation of the infant before the test to distinguish normal behavior from behavior in response to sound. Now think about that really quickly this is not just a bullet on a slide. It ensures that the person understands how the child is responding in a normal condition, and then contrasts that to how they respond to sound. So think about that. And if you're in an early intervention setting and you're working with a newborn who's just been identified with a hearing difference, you're going to need to be able to observe and describe normal behavior and the behavior in response to a sound. So we have here that it's a subjective observation by the audiologist that requires a lot of experience. A smart audiologist will not rely only on themselves for these observations, but will recruit the knowledge of the parents, the families, the caregivers, as well as the early intervention team. The stimuli that's presented may include speech, warble tones, narrowband noise, the parent's voice, an early intervention's voice, usually through loudspeakers. And I've got a video here for you that you can look at that I'll post into the Canvas page. So when we're thinking about the oral rehabilitationist, we are looking at what are the behaviors that are present when this little child can hear or detect a sound, and what does it look like when a sound is present versus when a sound is not present. It could be a sucking response. It could be eye widening or looking around response. It could be a flinch. It could be a startle. It looks different for every single child. And so early intervention providers must know what to be looking for and be constant detectives of, I think that was a response to a sound. Not only it's a response to a sound, but also be very smart about what sounds they're presenting and keeping good data on this. So it's really about being detectives, and not only being early intervention detectives, but empowering families to understand what these responses might look like and how they can also keep track to the responses of their child to differentiate normal responses without any sound present versus responses with sound. It's a key part that is often overlooked. As we move forward, we start getting into visual reinforcement audiometry. This usually happens between 7 and 24 months of age, depending again on the developmental skills of the child. The stimuli can be presented via earphones or the loudspeakers. The child is taught or conditioned to turn their head when a sound is heard. Once again, an oral rehabilitation early interventionist is aware that the child is going to be asked for a visual head turn response, VRA, a visual response audiometry. So what can happen is, in an early intervention session, the interventionist can turn to support or teach this head turn response in the home setting. in an early intervention setting. Typically, what this looks like for me is that I'll be in front of a child, or the parent will be in front of the child doing some very, very mildly entertaining activity. It can't be too entertaining because then the child will be too engrossed in the activity that they won't be listening for sound. So they do something very, very simple in front of them, and then a sound is presented behind the child, so all the way behind. And when the sound is presented, then we try to train that child to do a good head turn and then do reinforcement like bubbles or something behind them. When we can try to teach these head turn responses within our early intervention programs, then we have much more success when they're in the audiology booth because they're not unfamiliar with the task. Again, if we're working on spoken language, an auditory-based spoken language component to the child's communication, having optimized hearing technology is a key part of what we need to be able to do. So us helping the audiologist to get good thresholds helps to help the fit of the hearing technology, which helps them to be able to access communication through auditory senses. The next piece that we look at is behavioral tests. This may be play audiometry. The next level that we have is conditioned play audiometry or play audiometry. This usually happens when the child is between 2.5 and 5 years of age, or until the child can perform a standard hearing test, which is more like raising hands like an adult. There's a lot of different things we can do to engage the child to respond to a sound. It could be putting a block in a bucket, placing a peg on a board, clapping their hands. It really doesn't matter a ton what we're doing. We just need consistent responses to the sound. It's a tricky thing, and it's really where the art of the science of hearing assessment goes, because you want to have something that's engaging for the child but not distracting for the child. So if you're doing a puzzle, if you do a really hard puzzle for the child, they might be more engaged with the puzzle than they are in listening. So it is a tricky thing. Again, this is a key thing that an early interventionist can do, or even a preschool can do, to ensure that there's some carryover. So if you're working on frogs in the classroom and you have little plastic frogs, maybe you could have the child bring some of those into the audiology booth. So then that way they're familiar with the task. Again, this takes a team approach when you're working with young children. I would say the other thing to really consider here is that you still always want to be a detective and look for behavioral responses throughout all of childhood, right? So no matter if they are, how old they are, you're going to need to be able to look at what's a behavioral response. Because sometimes they won't condition to dropping the block, or they're only drop the block when they really hear something super loud. I just was with a child the other day, and I was presenting a sound very quietly. I was going, shh, 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 and she wasn't responding. She was not responding. And then both the two other adults in the room were like, oh, I think it's behavior. I think she's done with the testing. And then I went, ah, and she responded right away, ah. And so it wasn't just behavior. That she wasn't wanting to respond. It was that she couldn't hear it. So we had to really turn up that hearing technology to have her have better access. So we had to look again, not just at the behavioral response of dropping a block or the play audiometry response. We had to be able to look at the behaviors. So it really does take a team there to be able to consider what is an auditory response versus a behavioral response. So what we want to be able to think about is that behavioral tests will include hearing thresholds for pure tone, both air conduction and bone conduction, speech recognition threshold tests, which is looking at what threshold or what level can they recognize speech, word recognition tests, which is going to be responding to a sound and repeating a word, as well as maybe getting some most comfortable level units, which is what is the level that they can be able to hear the very softest sounds, and then uncomfortable levels is which are the very loudest sounds that they can respond to. Unaided and aided audiograms, and then these are all responses, and they're all shown on an audiogram. So these are some of the tests that we might, a battery of tests that we might put an adult or a child who has maybe a school-age child to go through. All of these tests are very important for us to be able to get good information about how the person is hearing with that hearing technology and how we can program that technology to optimize audibility or accessibility for spoken communication. Now, I'm sure that you've seen audiograms before, but do you have experience explaining them to someone without any experience with hearing loss? That's what we do in oral rehabilitation almost every single day, is that we have to be able to think about how do we explain this type of audiogram, this picture of hearing to someone with no experience with that. This happens constantly with families, that they're given the audiogram, but they don't really understand what it looks like. So, or what they're getting or what that means. And so this is a good opportunity for you to be able to think about it. And then I'll also give you an example of a common sounds audiogram. And so you can take a look at maybe how to map an audiogram onto that, so that you can better explain it to someone else. So we have low pitches to high pitches along the horizontal axis. From left, we have low sounds to high sounds. And I usually talk about this similar to a piano, where we have very low sounds over here and very high sounds over here. And we describe pitch as frequency or hertz. Then we have very soft sounds at the very top, and then all the way going down to the very bottom. We've got the normal range for children and a normal range for adults. You notice that the normal range for children is slightly above where a normal range for adults is. Well, less, I guess, if you think vertically. Hopefully this is review for you for the audiograms symbols that we have always red for right, blue for left, and then you can also see air conduction symbols as well as air conduction as well as bone conduction. Sorry about that. Air conduction symbols here, bone conduction here. And then this is when without aids, and this is with a speaker, you have an S, and then we have right aided. Again, red is right, left aided. If it's both ear condition, we have a black A, and then a cochlear implant, we have the same. So air conduction means that it is going through the canal, through the ear canal, and we're testing the entire system. So it means air means that you're doing the sound that comes all the way through from the ear. It cannot tell us about the type of hearing loss because it's testing the entire system. So this is looking at an air conduction hearing thresholds. So here we have red for right. The red is the right ear, and then the blue is the left ear. And so you could say that it was a sloping hearing loss, right? Was normal to moderately severe or severe, right? And this would be a bilateral hearing loss because both ears look very similar. Bone conduction takes away the outer ear component and it sends the sound through the temporal bone into the cochlea. So it bypasses the outer and middle ear and it tests the integrity of the inner ear and retrocochlear audio pathways. Bone conduction tells us about the type of hearing loss, conductive, sensorineural, or mixed, by having an air bone gap. So if this is what we get through air, right? So the sound is going through air and we get this response. But then when we take out the outer and middle ear and we get a better response, then that shows that there's a conductive component to the hearing loss. Because when we bypass that part, this part of the ear, the inner or the retrocochlea parts, are seeming that they're within normal, well, not within normal limits, but they have a better response to sound. So there's a conductive component because of this air bone gap. So when you see a difference, that will be a conductive hearing loss. So again, remembering that there's conductive hearing losses, sensorineural hearing losses, as well as mixed hearing losses. And then sometimes we can see central auditory processing disorders where the sound is all coming in okay, but that the brain is having a hard time making sense of sound. Sometimes we can have a neural hearing loss, like auditory neuropathy, and that means that the nerve is misfiring or dysynchronous when it's firing. And so is a very interesting type of hearing loss that if you have questions about, let me know, and we can do an office hours that talk about auditory neuropathy. And then sometimes we can also see a functional hearing loss where the system is all actually working just fine, but that the individual is still reporting that there's a hearing loss. And there's a variety of different reasons that may happen. And so I think that's often means a referral or sometimes a psychological component to that, depending on the level of the functional hearing loss and sort of the case history behind that. So as we look at this, we could see that bone conduction test here, right? The bone conduction is normal and the air conduction has a hearing loss. So this would be a conductive hearing loss because what we're seeing here is that when we bypass the outer or middle ear, that this hearing seems normal. So this is a conductive hearing loss. A sensory neural hearing loss, we don't see that difference between when we bypass that outer ear or middle ear, they're exactly the same. So that means that there's something that is going on with that there's this is a sensory neural hearing loss because that we can see that there's the bone conductive as well as the air conduction has a hearing loss. So when you bypass that outer or middle ear, you're still having a hearing loss. So sensory neural. A mixed hearing loss is that even when you bypass it, there's still a hearing loss. So this is that there is a mixed hearing loss because you see that this is when you go through air, this is when you go through bone conduction. There is still an air-bone gap, but there's a hearing loss within both of these different components. I hope that makes sense to you. If you have any questions, please let me know. Pure tone average is the arithmetic average of the air conduction hearing thresholds at frequencies 500, 1000, and 2000 hertz. It's the sum of the thresholds divided by 3, which is the average. Sometimes 4000 hertz is also added to the calculation, which we call PTA4. This helps determine the degree of hearing loss. When we think of degree of hearing loss, we have normal, slight, mild, moderate, moderately severe, severe, and to profound. And there's some very interesting research about slight and mild hearing losses and the psychological impact of using those words with families, because sometimes when they hear that there's a slight or mild hearing loss, they don't take it as seriously. But as we'll talk about in our acoustics or perception module, it still will have a great impact on the child's ability to access particularly some of those high frequency phonemes that are important foundations for spoken language. When we plot that degree of hearing loss on the audiogram, you can see we have normal, slight, mild, moderate, moderately severe, severe, and profound. There are some great simulations that tell us a little bit more about how the degree of hearing loss impacts communication. It is not enough to look at pure tone average to determine the degree of hearing loss. If you look at these two different audiograms, the PTA could be the same, but the impact of the thresholds is very different. Whereas this person may have much more difficulty with hearing sounds all the way from 2000 to 8000 hertz, where this person on the left just may have a lot more access to sounds, except in the very high frequencies. The hearing loss configuration describes the shape of the audiogram. There are various configurations that we need to consider, and I'll show you some of those. A flat audiogram means that there's a little to no change in thresholds across the frequencies. A sloping audiogram, as the frequency increases, the degree of hearing loss also increases. The hearing in a high tone hearing loss or a high frequency hearing loss, we have more less hearing in those high frequency sounds. This is pretty common and very interesting from us from an oral rehabilitation standpoint when we consider how much language, including grammatical morphemes, happens in this high frequency area. A low tone or low frequency hearing loss is also sometimes called a rising hearing loss. And so this means as the frequency increases, the degree of hearing loss decreases. So you'll see that there's low frequency, more of a hearing loss in those low frequencies and less in the high frequencies. In terms of oral rehabilitation, this may give us more difficulty with vowels and nasals. A U-shaped or cookie bite hearing loss, we have low frequencies and high frequencies that are relatively preserved, but that we have more of a hearing loss in the mid frequencies. Again, this may give us more difficulty with some of our vowels. A reverse U-shaped or tent-shaped hearing loss is that there's more hearing loss in the low and high frequencies, less in the mid frequencies. And this might be what we might see with this is that vowels are actually relatively preserved, but we're going to have a lot more difficulty with consonants. A notched hearing loss is very common with someone with a noise-induced hearing loss. So that what you'll see is that it looks, it's unilateral here on this left side, that we see a unilateral hearing loss in the left ear. And relatively normal in the right ear, but we'll see that, and this could be that there was an exposure on that left side. So you can see that that left loss has a notch. So that would be asymmetrical hearing loss. Here is a symmetrical notched hearing loss. So it's within normal, then notched to mild, right here around 4,000 hertz, and then goes back up to normal. A corner audiogram. So this is someone with a very severe to profound hearing loss, but that they might have some information in this in low frequencies, but then very, very little hearing in those higher frequencies. This is you can see that there's a little bit of a difference between the conductive versus the sensory neural or the bone conduction versus air conduction. And so this would be both a mixed hearing loss. Unilateral hearing loss, you can see this again is that within that right ear, we have less hearing loss, and then may even be I would say mild hearing loss, but we notice that in this left ear that there is a much more of a hearing loss, sloping hearing loss. In the right audiogram, we can see that the conductive results are within normal limits, but we have in the right ear that there is definitely noticed that there is a difference here. And so that would be a unilateral hearing loss in the right ear. So you can see that the hearing loss is limited in these to one ear, and that the type and degree of hearing loss in the ear with the hearing loss can vary quite a bit. Single-sided deafness, we see that the thresholds in the impaired ear are within the severe to profound range. This is just showing us the difference between a symmetrical hearing loss that we see on the left and an asymmetrical hearing loss, which we see symmetrical hearing loss on the left and then an asymmetrical hearing loss on the right. The asymmetrical hearing loss is defined as a difference between 15 decibels or more between the right and left ears. Asymmetrical hearing loss can be sensory neural, conductive, or mixed. So it's good practice to be able to explain what you can see. And so if you consider that everything above the audiogram is what the person is having a hard time hearing, so they can hear everything underneath where the thresholds are. So on top is the things that are harder for them to be able to hear. So I'll put up some of these slides for you to be able to see so that you can practice this on your own. Let me know if you have any questions describing these to other people.